Good afternoon, madam.
Can you hear me? Can you hear?
Yes, madam. We can.
Okay, I'm going to knock off the video because my internet is again playing up, and I'll put it on for questions. Okay, let's see. So I'm supposed to talk to you about joint swelling and back pain. And I hope you can see my screen.
Yes, madam, we can see the screen.
Okay. Right, I'm trying to figure out where you guys are. Okay, so I'm going to talk to you about two basic topics. One is about joint swelling, and it'll again be in two parts: monoarticular joint swelling and polyarticular joint swelling. And the second part of my talk is about back pain, again in two parts: mechanical and sinister back pain. Okay, I'll put some MCQs along the way, and then it'll be easier for us to understand where we are going. So this is a 68-year-old man who presents with a swollen, red, hot left knee of 2 days duration. He has diabetes and chronic kidney disease and has renal transplant plans but no regular dialysis. Okay, only now you can see my application. You could see right earlier.
Madam, there is something in the middle of the screen that we can see. There's something downloading. Now
Really?
okay.
Oh, what is downloading?
Now okay, madam.
Now I can't see you. Okay, how about now?
We can see, madam.
You're seeing a screen selection. Give me a moment. I will sort that out. How about now?
Again, the downloading thing is there.
I'm wondering what is downloading. Give me a moment, right? Okay. Now can you see me? Can you see the screen now? Not really?
No, madam. We can. There are many boxes open, and the screen is.
Right. I'm not sure. I think I have gone to advanced Zoom settings for some mad reason. I'm going to stop the share, and I'll do a How about now? Now can you see?
Yes, madam.
Now?
Still, it's okay, madam. There are very small two boxes showing downloading. something
Okay,
in the
right.
middle of the screen.
I wonder what is downloading.
It shows downloading RH and some number.
Ah, okay, right. Fine. Now, okay.
There is another one, RH, another one. Now one has gone, another one is there.
Okay. Right. I think I know what's happening. Okay.
Okay, madam.
Right. Very sorry. I'm working from Google Drive, and this whole process has got messed up because of that, I feel. Right. Let's try again. How now?
Now, okay, madam.
Right. So, two components: joint swelling and back pain. And we'll start by a history of a patient with monoarthritis. If you can't see, please let me know. So this is a 68-year-old man with a swollen red hot left knee of 2 days duration, a diabetic with kidney disease and infrequent hemodialysis. So when this kind of patient comes to you, there are some questions that you need to ask of yourself. So first of all, people say they have joint pains, joint swelling. You need, as the doctor, to figure out whether it is actually a joint problem or some other periarticular structure. Then, if it is actually really a joint swelling, you need to know what the differential diagnoses are and how to differentiate between the two or more differential diagnoses. So, what are the non-joint swelling problems which can happen? What are the periarticular problems where a patient can present saying it's a joint swelling? Any other structures other than the joint, near the joint, which can be swollen? Anyone? Yes?
Bursa.
Bursi, absolutely. So any joint swelling, any periarticular structure like a bursa can be swollen. Any other things?
Tendons.
Tendons, yes. So bursae are spherical and they are discrete and they don't really connect within the joint. So they won't move or change when the joint moves. But if you have a joint swelling, when you move the joint, the swelling will change in size. If it's a tendon, it will look like a linear, like almost like a spindle or a line or a sausage shaped swelling. Any other things? So I think that's quite okay. So it is either a joint swelling or a periarticular syndrome, and that was called soft tissue rheumatism, I think, in your musculoskeletal module. I don't like that word much. I think of it like something caused a pathology of the periarticular structures. So it can be a bone. It can be a bone enthesitis, but enthesial swelling is not so big. Fibrous tendon sheath can be linear, synovial tendon sheath can be linear, or it can be a part of the paratendon. So if a patient says the joint is swollen, first of all, make sure that it is not a periarticular structure. So the articular or joint problems cause pain with all movements, and there is reduction in the range of movement, and there can be tenderness over the joint line. Whereas if it's a periarticular or a non-articular structure, you get pain on movement in one direction. So if there's a swelling over the patella tendon, it'll cause pain only when that direction of movement is there. If your subacromial bursa is involved, it'll cause pain only in that direction, and there'll be restriction of movement only in that direction, and the swelling is slightly linear and doesn't really merge with the joint structure. So if it's a periarticular problem, think enthesis, tendon, joint, bursa, or fascia. Okay, so this is in the shoulder. It can be a tendinitis, it can be a enthesitis, or it can be a bursitis, or it can be a fasciitis. Bursitis also can be red hot and swollen, and it can occur in crystal joint diseases, in trauma and in infection, or can be repetitive. And these are some pictures of bursi. And in this patient, the suprapatellar, infrapatellar, the pes anserine bursa can also be swollen. So, right, you examine this patient. There is a joint swelling and there is restriction of pain, restriction of range of movement when the joint is moved, right? So, what are the main findings here? So, this is your first MCQ. So this 68-year-old man, on examination, there is a left knee joint effusion and there is warmth and erythema. So this is actually a single best response, and it should read which one of the following needs immediate exclusion, and there are 5 responses. I'll let you all answer it while I figure out how to find your names on this screen. My computer is unfortunately playing up today. Yes, so what are the possibilities? Which one of the following which needs immediate exclusion? Only one is correct. Sorry?
Septic arthritis.
Septic arthritis, right. Of course, we need to consider acute gout and the other differential diagnosis. So, if you have an acute inflammatory monoarticular swelling, you need to consider infections and crystal joint diseases, as well as a monoarticular presentation of arthritis like rheumatoid arthritis, maybe psoriatic arthritis. So you need to consider this. So huge range of things which can cause a monoarthritis, but the most important way where we can differentiate between the very important cause of diagnosis in a monoarthritis is to consider septic arthritis. Very difficult to clinically differentiate acute gout, acute bursitis, acute septic arthritis. Bursitis, of course, clinically it is discrete, whereas and you can get it's like a lump really over the knee. But if it's septic arthritis or gout, the only way, or any other inflammatory disease, the only way you can differentiate between the conditions is to do a joint aspirate. So if you do a needle aspiration or an ultrasound guided aspiration and it's septic arthritis, you get a very purulent yellow murky fluid with very high neutrophil counts and very low sugars, and sometimes the gram stain can also be positive. If you think of rheumatoid arthritis or other inflammatory conditions, it is very unusual to get white cell counts more than 40,000. Sometimes you can get between 10 and 40,000, but more than 40,000, 100,000 is very, very unusual in inflammatory joint diseases. Have you all seen patients with septic arthritis? Have you? Yes? Have you seen? Anyone? I'm waiting.
Yes, madam.
Okay. And what kind of organisms were usually the cause of septic arthritis in the ones that you have seen? Anyone? Does anybody like to answer that?
Staphylococcus aureus.
Yeah, so you usually see Staph aureus, but it depends on actually the person. And sometimes if you have diabetics or immune compromised patients, you might see other a little more exotic kind of organisms, right? So when you have a patient with septic arthritis, that patient needs admission. You need to aspirate the joint either blind or under ultrasound guidance and send the joint fluid for culture, full report, sugar, accompanied by blood count, inflammatory markers, and blood sugar. And then you immediately start antibiotics according to whichever hospital you work in, right? And then while pending these the joint aspiration reports, you start the antibiotics. Okay, the commonest antibiotic we start are things which have gram positive covers. So coamoxiclav, flucloxacin are used. But if the patient is has had a long hospital stay, has had other comorbidities, you can even use meropenem or more expensive antibiotics like teicoplanin. But the initial antibiotic is usually a gram positive antibiotic. So how do you give this antibiotic? I asked it in a question, structured essay question some time back. Tell me what are the principles of treating septic arthritis? Anyone? Yes? What are the principles of treating septic arthritis? Yes? Would somebody like to answer this question? Yeah? Anyone? Oral or parenteral? It's up on the board. Yeah?
Parenteral.
Why parenteral and why not oral?
Because the blood levels of the antibiotics should quickly reach the therapeutic levels, because
Yes, that's correct. And they also need to go into the bone, which is not easy. So they have to have good tissue penetration. So you need intravenous antibiotics given intravenously for at least 2 weeks. You also need to clear the pus within the joint by arthroscopy, right? In our resource poor setting, we tend to do repeated joint aspirations, but that is really not good enough. You need an orthopedic surgeon to, under ultrasound guidance, under arthroscopic guidance, to wash out the joint, because if you leave any pus or organisms within the joint, the infection will not heal. So this is the kind of antibiotic profile that is used, and you need to use local and institutional guidelines. But in principle, gram positive cover unless it's an elderly person with a risk for gram negative sepsis. The other second differential diagnosis in this person is gout. You all have seen gout, isn't it? Yes? Anyone? No one has seen gout. Ladies and gentlemen, if you do not participate, it becomes like I am just talking to the screen. I can't see all of you, and I was planning a physical lecture, but the CleanMark cannot be open due to curfew, so I had to do it like this. So if you interact, it is better, because otherwise it becomes very, very boring, particularly for me. Yeah? Anyone seen? You have seen? Right. Okay. So, you know that patients, what kind of presentations have you all seen? Can two people tell me how your patients presented with gout? Yes, please.
Madam, I saw the patient who presented late, and he had picto gout and as well as tophi formed in the earlobe as well, madam.
Right. So he's a patient who has chronic tophaceous gout who presents with acute gout. So, as you know, you can have asymptomatic hyperuricemia, and then after a particular period of hyperuricemia, you get what we called acute intermittent gout. And if this gout condition is not treated, you get chronic tophaceous gout. And even though you have chronic tophaceous gout, there can be episodes of swelling. So on the left side of your screen is acute gout, and on the right side of your screen is chronic tophaceous gout. How do you treat? You avoid things which increase the uric acid levels in your body. It is also important for people to reduce their body weight, have regular exercise, because those will improve uric acid. It will reduce the metabolic risk, which is caused by increased uric acid, and it becomes really clinically easier to treat the hyperuricemia. So how do you treat gout? You treat gout you treat the acute attacks with colchicine if the patient has chronic kidney disease. If they don't, you can use non-steroidal anti-inflammatory drugs or coxibs to treat. So in very severe attacks, you can use intra-articular steroids or oral steroids. Prevention is with allopurinol or febuxostat, but prevention must be started for the first time only 2 weeks after the acute episode has settled. Okay, so these are the pharmacological agents we use in gout, and there is a big list of drugs. And are there any questions about how to treat either septic arthritis or gout before I move on to the other conditions which cause a monoarthritis? Yes? Are there any questions? I'm very happy to answer your questions.
Madam,
Yes, please.
Madam, in the joint aspiration done in septic arthritis, for what investigations should we send the samples?
Okay, so thank you for the question. You aspirate the joint fluid and you send it for what we call a full report. The joint full report will have a lot of parameters like what I showed you. You're interested in the color, the turbidity, the protein, the cell count, the presence of crystals, and the presence of any organisms, right? So that is the full report. You also need to send the sample for culture. I tend to send it in a blood culture bottle, but people do send it in the normal standard urine culture kind of bottle. You also need to send the joint full report in a sugar bottle because you need to assess the joint aspirate sugar content. Just like in the cerebrospinal fluid level, you need to pair it with a random blood sugar at that time. Have I answered your question?
Yes, madam. Thank you.
Okay. Are there any other questions? I'm very happy to answer.
Madam,
Yes.
yes, in gout, when do we stop the acute treatment and start preventive treatment? How long we
Okay. Okay, very good question. Typically, within a week, the acute episode settles. And after the acute episode settles, you put the patient, this is a new diagnosis, you put the patient on a urate lowering drug, treat their underlying condition, be it chronic kidney disease or whatever, by the normal method. And after 2 weeks of the acute episode settling, you can slowly, gradually start the xanthine oxidase inhibitors. Did I answer your question?
Yes, madam. Thank you.
Okay. Are there any other questions?
Madam,
Yes.
madam, what's the reason behind
Because
starting
give me a
the
minute.
allopathy
Yeah.
after 2 weeks?
you started after 2 weeks because what really brings on gout is actually a very rapid fluctuation in uric acid levels. Okay, so I just want to get people's names right. Okay, so because of the fluctuation, so when you I'm trying to log in on my phone to see. Sorry. I can't see all on the on my screen. For some reason, the cursor has stopped working, and I was trying to log in on my phone. Bad idea. So anyway, fluctuation in the uric acid levels can trigger gout. So you go from high uric acid level to low uric acid level. That can actually trigger gout episodes. So you need to have baseline, well-controlled uric acid levels before you actually start the long-term preventive medicine. Did I answer your question?
Yes, madam. Thank you.
Okay, sorry about the technological hiccup. Today is not a good day. Yes. Are there any other questions about either septic arthritis or gout?
Madam, if they get an acute attack while they are on the preventers, what do we do?
Then you don't change the preventer. You just treat the acute attack. But that actually means that the preventer dose is not enough and the patient is not really adhering to the lifestyle measures. So you will increase the the preventer only after 2 weeks of the episode settling. Is that clear?
Yes, madam. Thank you.
Okay. Are there any other questions? Because I mean, I think you get a huge information overload about these conditions, and even in this lecture, there is not enough time. But as students and junior doctors to be, there are many questions, and the purpose of the clinical lecture demonstration is for you to understand those principles. Questions are very welcome. Any more? Yeah. Are there any more? Okay. So the other condition which can present with acute monoarthritis is actually knee osteoarthritis, and but this doesn't cause redness, hotness, or swelling. And you know that knee osteoarthritis is clinically diagnosed, and X-ray changes also help you diagnose osteoarthritis. But I've told you that osteoarthritis is a multiple involves multiple components of the joint, and this paradigm is very, very important in treating. So the treatment of osteoarthritis, I don't need to go through here. The purpose of it was for us to discuss any issues that you have with management. And so basically, conservative treatment works, weight loss, exercise, and biomechanical correction works. Pharmacological agents are useful just to reduce the knee joint swelling, and other things like glucosamines, hyaluronic acid, platelet-rich plasma, all have a very modest or minor clinical benefit and have really not been proven in clinical trials. But in this patient, you can consider it. But redness, hotness are very, very unusual in knee osteoarthritis. But I wanted to bring this topic up so that we can discuss it, because the topic is actually joint swelling. So are there any questions which I can answer about osteoarthritis? Yes? Any questions? Anybody has any questions about osteoarthritis management? Lots of myths, lots of things are being tried in the private hospitals, in the government hospitals, some of which don't work. Are there any questions about osteoarthritis that you want to ask me now?
So, madam, what are the indications for arthroplasty in osteoarthritis?
Okay, if your conservative treatment, that is weight loss more than 10%, biomechanical correction, and those things don't work, and the patient is having severe chronic pain which interferes with their lifestyle and which interferes with their sleep, that is an indication for joint replacement. And but the issue is that patients who don't undergo the conservative treatment, who get joint replacements without losing weight, without strengthening their legs, without correcting their biomechanics, their outcome is poor and they get repeated joint pains. Did I answer your question?
Yes, madam.
Okay. Are there any other questions? Happy to answer. Any other questions? Okay, I put this slide up just to wrap up the section about monoarthritis to tell you that hemarthrosis due to injuries, due to any bleeding tendency can also cause a red hot joint, and that is an extremely painful condition. Occasionally, and I've only seen one, you can have a tumor masquerading as a monoarthritis, but by far the commonest causes of monoarthritis are infections, crystals, inflammation, right? Not the other ones. But there is also chronic monoarthritis, and that is in our condition usually arthritis of one joint, which is going on for more than 6 to 8 weeks. Common conditions are a monoarticular presentation of an inflammatory joint disease and tuberculosis. If you have a chronic monoarthritis and you don't think it is a inflammatory joint disease, or you're really not sure, it is a synovial biopsy is indicated. The synovial biopsy will help us
Recording in progress.
Who has multiple large and small joint arthritis, and she has taken Ayurvedic treatment for the 4 years, and now comes with acute large and small joint arthritis. So again, you need to ask this yourself whether it's actually joint swelling in all the joints, because I've been referred many patients and they have a tennis elbow, a knee swelling, Achilles tendonitis, and my students are referring these patients saying they have polyarthritis. So make sure that all the joints which are involved are actually swollen. The second question is to identify whether the joint problem is inflammatory or mechanical, because you can actually get a combination of these things. And the third thing is to identify the pattern of joint involvement and the associated joint symptoms. So the first question to answer, is it inflammatory or mechanical? Because you can get osteoarthritis of multiple joints. You can get it in the hands, you can get it in the knees, you can get it in the hips, you can get it in the ankles. So you really need to differentiate osteoarthritis from other inflammatory joint diseases. So how do you do that? Jayani, let me know. How do you do that? Yes? Tell me, how do you differentiate inflammatory joint disease from age-related degenerative mechanical joint problems? Yes.
Madam, you can look for inflammatory markers.
You can, but let's do it clinically. We'll pretend the lab is on strike. Trade union action. Clinically?
There will
Yeah,
be
we can-
significant early morning stiffness and pain.
Correct. Any other things?
Madam, the age?
Okay, but age is, so if you are, so this problem came up, thanks for bringing it up. This problem came up when I gave a question, again a structured essay question of a 23-year-old with hand joint swelling and people considered osteoarthritis. That we didn't accept, but in general, we should go mainly by early morning stiffness, which is lasting more than a few hours, which improves with activity, which is worsened by rest, where there is profound fatigue and tiredness, and there is also anecdotal information that the patient is better with anti-inflammatory agents. If you examine these patients' joints, they are rubbery and swollen, not bony swelling. So these features are helpful to differentiate rheumatoid arthritis and other inflammatory joint problems from the mechanical conditions or degenerative diseases. So first, you have the patient, you make sure that it is multiple joints which are swollen, not one joint and an enthesis, or one joint and a fascia, or one joint and a bursa. Then you go to the pattern of joint involvement. In rheumatoid arthritis, you get symmetrical swelling of the wrist, the metacarpophalangeal joints, the proximal interphalangeal joints, the tarsal, the metatarsophalangeal joints, the temporomandibular joints. In spondyloarthritis, you get asymmetrical lower limb joint swelling with asymmetrical upper limb joint swelling. If it is gout, it is predominantly lower limb swelling. So you, depending on the pattern of joint involvement, again, you can reach a clinical diagnosis. The other one which helps is to go through the associated symptoms. So if it's rheumatoid arthritis, established rheumatoid arthritis looks different to early rheumatoid arthritis. So in established rheumatoid arthritis, you get the typical joint inflammation, joint damage, Boutonniere's deformities, ulnar deviation, swan neck, claw toes, hallux hamartosa, hallux valgus, the rheumatoid nodules, and you get these typical changes which tell you, right, this is established rheumatoid arthritis. Don't forget the cervical spine involvement with atlantoaxial subluxation, and also don't forget the extra articular manifestations of rheumatoid arthritis. You get pyoderma gangrenosum, you have amyloid, you get scleritis, scleromalacia, rheumatoid nodules in the lung, in the elbows, pulmonary fibrosis, Kaplan syndrome. So many. This is actually an ulcer in a patient who had Felty syndrome as well. So many features which actually point to you that you have rheumatoid arthritis. I think your book still have the old classification criteria, and these are useful in established rheumatoid arthritis. If you are not sure of the clinical diagnosis, you can use classification criteria. If you have a patient who is your long case with rheumatoid arthritis, your normal clinic patient with rheumatoid arthritis, please assess them for coronary artery disease, ischemic heart disease risk factors. Please assess them for osteoporosis. Please assess them for lipid derangement. Remember, rheumatoid arthritis causes inflammatory markers to be on overdrive, and vascular conditions are common in rheumatoid arthritis. If you have early rheumatoid arthritis, you will not see all these multi-system involvements. So this is a 32-year-old lady doctor from Kalutara. I've changed the location. She presents with large and small joint arthritis, and when you examine, there is just mild joint tenderness, no deformities, and there is some synovial swelling. Her hands look like this. There is spindling, which is marked in both sides. So another question. Which of the following diagnoses are likely in this patient? Yes. Okay. Anyone? This is a true-false question. Multiple true-false responses. Yes. Anyone? Is chronic tophaceous gout likely?
False, madam.
False. How about hand osteoarthritis? Anyone? Who thinks it's true? Who thinks it's false?
False, madam.
Why is it false? We'll talk about it. I agree. Psoriatic arthritis? True or false? Yeah. True or false? Come on. What do you think? In the lady doctor. Yeah. Rheumatoid arthritis? Systemic lupus erythematosus? Has
True.
True. Okay. Which are true? Which ones are true? Psoriasis, rheumatoid arthritis, SLE, all three, or one of the three, or some of the three?
All three can be.
All three are
Yeah.
correct, yeah. So those are the correct three answers. I will explain chronic tophaceous gout, clinically unlikely. The patient would have had episodes of acute gout, and in the history, on examination, there have to be tophi and multiple deformities. This patient in later. And yes, so this is early arthritis really, but because there is only joint swelling and inflammation, and early arthritis looks like this. But frequently, even in early arthritis, you can see rheumatoid nodules. I gave a long case this time for the final exam. A patient with arthritis for 4 months, just joint pains and joint tenderness, and only one of the 6 candidates picked her rheumatoid nodule. They were very small, but still one person picked it. So remember always in early arthritis to look for rheumatoid nodules. Also look for nail changes and psoriatic plaques. Psoriatic plaques can be in the scalp, in the perianal region, right? And in the shin. So if you don't examine properly, you will not see. You might see onycholysis, but frequently in early arthritis, you see thimble pitting, and these are more often seen in the toes. So remember to examine the patient, inspect the patient very carefully. Always ask for features of autoimmune connective tissue disease, because patients can still present with symmetrical arthritis. Okay, so Sjogren's syndrome, lupus, look for features of Raynaud's. I don't know if you can see that the hand which is there has blue is blue, slightly blue, and there are white, the fingertips are white. So look for all those features. Look for sclerodactyly. Look for a pinched mouth, or because all these features can make you make a tentative diagnosis. Okay. What are the investigations? You will do a rheumatoid factor titer, an anticyclic citrullinated antibody titer. In other countries, you would do anti-nuclear antibodies as well. In our country, sometimes the patient delays doing it. And the ideal method of diagnosis in early arthritis is a high resolution ultrasound. But if you have advanced disease, you can use X-ray imaging as well. So this is early arthritis. You just see periarticular osteopenia. Here you see early small erosions. As I said, I have lost my cursor, but if you look at the mid erosions in the proximal, and this is arthritis, you see carpal sclerosis,
Recording stopped. Recording in progress.
Hello? Can you hear me?
Yes, madam.
At which point did I get knocked off? My connection went. Which point did you miss my talk? Did I finish disease activity levels according to the talk?
No, madam.
Where was I, Dushanti? Where did I stop?
I think it was in the X-ray.
Okay, fine. Sorry. My internet connection has gone. It's failing repeatedly. I'm going there now. Can you see my screen?
Yes, madam.
Yes,
we can
madam.
see.
Okay. Did you see these early inflammatory arthropathy x-rays? These ones?
Yes, madam.
Okay. If by chance you get cut off, can you give me a call, the batch rep? Okay, because I don't know when you have got cut off. Right. So this is early inflammatory joint disease where you get periarticular osteopenia. And this is established rheumatoid arthritis early, where you get juxta-articular erosions. If you look at the metacarpophalangeal joints, you can see them. And this is established rheumatoid arthritis with joint subluxation, extensive erosions, and periarticular sclerosis and joint sclerosis in the carpus. In psoriatic arthritis, you get asymmetrical involvement. In this hand, it is on the right side. You get pencil in the cup deformities, which are seen in the distal interphalangeal joints in this patient. In hand osteoarthritis, though we didn't consider it in this young doctor, you get extensive osteophytes and a seagull appearance in the distal interphalangeal joints. Again, chronic tophaceous gout we did not consider in this young woman without a previous history. And here you see juxta-articular, not periarticular, shelf-like erosions. So you make your diagnosis based on multiple joints being involved. You assess whether the joint swelling is inflammatory or not. You examine for associated features, and you do imaging and immunology. Assessing disease activity is important because you treat to target, and this is done by assessing disease activity measurement tools. And you need to reach your target within 3 months. If you don't, you have to escalate therapy. Treatment is done with a multidisciplinary team. Steroids and conventional disease modifying drugs are the mainstay of treatment, and conventional disease modifying drug methotrexate is the #1 disease modifying agent. You combine methotrexate with steroids initially, but if that does not work, you can add on hydroxychloroquine and sulfasalazine, or make it methotrexate and leflunomide only. If this does not work, at every 3 monthly intervals, you increase the doses, change the conventional disease modifying drug combinations, and if that still does not work, you add a biological disease modifying drug or a Janus kinase inhibitor. Okay, so what you need to know as a finally a medical student is that we use disease modifying agents. I chose this opportunity to talk about spondyloarthritis disease activity, though this patient's symptoms were really not compatible. Again, you have a scoring system and you use that to assess if the patient has met your treatment target. In axial spondyloarthritis, you treat with non-steroidal anti-inflammatory drugs, and these are disease modifying. And if they don't work, you go to anti-TNF therapy or interleukin 17 or interleukin 23. Peripheral joint disease is managed exactly almost like rheumatoid arthritis, but the preferred agents are sulfasalazine and methotrexate. So this is our original case patient who had multiple large and small joint pains with Ayurvedic treatment and extensive joint deformities. So in this patient, what are the possibilities? I'll let you look at the history again for a second. What are the possibilities? Anyone? Can it be ankylosing spondylitis? Yeah. Can it be? Clinically? Yes or no? Anyone? Very unusual because ankylosing spondylitis typically does not cause a lot of hand deformities. How about hand osteoarthritis?
Probably not.
Probably
Because of the duration of the symptoms and
the intensity of the symptoms, and also because of the significant early morning stiffness. So very unlikely to be hand osteoarthritis. How about rheumatoid arthritis?
it can be.
It can be. How about psoriatic arthritis?
It is also possible.
It is also possible, yes. How about systemic lupus erythematosus? Today is World Lupus Day, I'm told. How about that? Yes? Yes? No? This is not I am not marking you. I am not judging you. This is only for us to discuss. So how about systemic lupus erythematosus in Nandavati Manike?
It's also possible.
Actually, it is not, because systemic lupus erythematosus typically does not cause worsening joint deformities. So it is not correct, right? But thank you for discussing that, because every question there will be a bit of a double whammy kind of question. So what is not included? Hand osteoarthritis is not included, mainly because there is in hand osteoarthritis there is no early morning stiffness of significance. The carpometacarpal and distal interphalangeal joints are involved, and the deformities also tend to be predominantly in the distal interphalangeal joint or in the thumb or in the first metatarsophalangeal joints. Okay. So that's why hand osteoarthritis really became unlikely here. Spondyloarthritis also is unlikely. Again, as I mentioned, it is unusual because of those findings which I mentioned, right? So in this patient, when we examine her, she is thin, cushingoid and pale, and she walks with a stick, and there is a rheumatoid nodule, and she has rheumatoid hands and feet. Those hands I showed you with ulnar deviation of the fingers, radial deviation of the wrist, Boutonnet deformity, swan neck deformity, Z thumb. So she has all those deformities, and she has multiple joint synovitis. Her lung bases are clear, and her blood pressure is normal. What investigations would you order? Please answer.
Inflammatory markers such as CRP and ESR.
Absolutely. To assess the level of inflammation, you will do the erythrocyte sedimentation rate and C-reactive protein. Any other things? Any other things? Any other things?
Rheumatoid factor, madam.
Rheumatoid factor theta is very important. A marginally positive rheumatoid factor is not significant, and you're thinking 3 times or 5 times in the case of anti-CCP antibodies. Just a marginal positivity is not enough. Yes, very good. Any others? Any others? Okay, I would do a blood count because the patient is pale and she has had long-standing rheumatoid arthritis. She has used Ayurvedic treatment. She has used painkillers. So I need to know whether there is a microcytic indices which is present, whether the platelet counts are high, whether there is marrow suppression with the Ayurvedic treatment. I will do a full blood count. I will also do a liver and a renal function test because I am thinking of putting her on conventional disease modifying agents, and I need baselines before I start it. I'll do an x-ray of her hands and feet because I need to know whether there are deformities, whether there the extent of erosive disease in the hands and feet. I'll also do the antibodies like you suggested and the rheumatoid factor, and I'll also do a chest x-ray because she has long-standing rheumatoid arthritis. I need to know whether she has interstitial lung disease. Okay, so these are the investigations. These are the ones you will do when you have a patient in the exam. So rheumatoid factor, not very specific, but very sensitive. Anti-CCP antibody, fairly sensitive, but very specific. So how will you treat this patient? I'm waiting for suggestions.
Madam, can we also do a full fasting blood sugar as she's having cushingoid features and because of the
Absolutely. That was
complications
going
of
to
the-
come in my next slide. I'm going to assess her for cardiovascular risk and diabetes. There is a slide coming up. Absolutely, yes. Totally correct. So how would you treat this patient? Anyone? Anyone? Why don't you start? A multidisciplinary treatment approach is needed. I will consider what drug? Yes? People, I need to move on.
Methotrexate.
Methotrexate will be tried, yes. So first assess the level of disease activity, confirm the diagnosis and treat. So her erythrocyte sedimentation rate is very high, her C-reactive protein is very high, her white cell counts are very high, her platelet counts are very high, and her hemoglobin is low. She can't afford an anti-CCP antibody, but her rheumatoid factor is very high. So treatment is multidisciplinary. You need pain relief, she needs occupational therapy, she needs physiotherapy, and she needs disease modifying drugs. And we choose usually conventional synthetic disease modifying agents, and methotrexate, just like you said, is number one. There are other targeted agents and biological agents, but we always start with methotrexate first. You need to start treatment early in this patient. We have missed the bus. We need to treat to target, and this is the most important thing, to treat to target. So how do you monitor the patient? You do the disease activity scores. You monitor the patient using disease activity scores. This is a screenshot from my Rheuma Helper, an app to assess disease activity. You start this patient on methotrexate. Usually start with a minimum dose of 10 milligrams with 5 milligrams of folic acid, and then you try to reduce the drug. But the patient continues to have grumbling disease activity, so you add on multiple drugs. You need to screen for dyslipidemia, diabetes, and osteoporosis. Please don't forget vaccination, including COVID vaccination. So what happens to Nandavati Manike? She is sent back to Kurunegala. She is from Maho. She prefers to go there. By that time, the rheumatologist there changes the disease-modifying drugs very correctly. She is put on leflunomide and methotrexate. She continues to have severe disease-modifying agents, and despite monitoring and treating to target, she is not reaching target. So if she was in England, she would have been screened for TB. Informed consent would have been obtained. The biologic specialist nurse and the GP in combination with the consultant rheumatologist would have probably started her on an anti-TNF treatment. In our country, again, same things were done, but because of the cost factor, she's commenced on rituximab because that is just 4 doses and not a monthly or injection, and therefore in the long term it is cheaper for our country. And so she doesn't have the luxury of a GP following her up in Maho, nor neither of a rheumatology specialist nurse. Both those people are very, very important. But she somehow, very persevering lady, comes to the rheumatology clinic at Kurunegala, and she achieves remission of rheumatoid arthritis, but on conventional disease-modifying agents. So we discussed the approach to a patient with polyarthritis. We talked about the common differential diagnosis, the importance of monitoring disease and treating disease activity to target. And we also assessed about importance of assessing for disease complications and comorbidity. Are there any questions? You also need to monitor for disease activity and side effects of treatment. Yes, any questions before I move on to part 2? Yes.
Madam, what did you do for the Ayurvedic treatment that she was already taking?
Yeah, we stopped it. Thank you for asking this question. I have no objection to oil application. In fact, I encourage it wholeheartedly. I don't like pattu application where they fix and immobilize a joint because that causes fixed flexion deformities. In terms of oral Ayurvedic medicine, there are very honest and very effective Ayurvedic practitioners, but there are many others who mix methotrexate and steroids to their Ayurvedic portions. So because we don't know what is there, we tell our patients to stop it. Did I answer your question?
Yes, madam.
Okay. Are there any other questions? Any others about rheumatoid arthritis, maybe psoriatic arthritis before I move to the next section? Any problems you all have seen, want me to clarify based on the patients you have seen during your clinical appointments? I'm really sorry, this is not a physical lecture, but ClinMark the whole of ClinMark is closed because of curfew, and I can't open up any lecture halls, and I couldn't delay your program also. So I had to make this Zoom. Next CLD, happy to do it physically, but while we are on Zoom also, you can ask your questions. It's actually easier to ask questions. Nobody knows who's talking, so please ask. Any questions? Okay, I'll move on to back pain then. This is a SCQ from the final exam. A 70-year-old man with severe nocturnal back pain and weight loss. He has it for a few months. I've forgotten exactly how much because I abbreviated the question for the slide. On examination, he is cachectic and pale. His spinal movements are nearly normal, but there is a lot of pain with movements. His ESR is 110. His hemoglobins are 6. And his white cell count is 3.4. Give 2 differential diagnoses for the back pain and tell what clinical features will help you differentiate this patient's back pain from mechanical back pain. Okay, can someone start?
It could be
Madam,
neoplasm for tuberculosis.
Okay, very good. The other person, that was Dushanti, right?
tuberculosis of the spine, madam.
Okay. Any other questions? Any other conditions? We had tuberculosis. What was the other thing you said? Neoplastic. Such as
Multiple myeloma, madam.
multiple myeloma. Any other thing? Metastatic back pain. Okay. What clinical features here suggest that it is a sinister back pain and not a mechanical back pain?
Nocturnal back pain and weight loss.
Absolutely. Any others?
Bicytopenia associated.
Absolutely. Any others? The cachexia, the pallor, and the high ESR. Okay. So the other is how you will differentiate between these based on clinical features and investigations. And the fourth part was how to manage the pain. So we come back to back pain. We have acute, subacute, and chronic back pain. And the cutoff of 4 and 12 is actually arbitrary. So generally, we classify back pain as mechanical or non-mechanical or sinister back pain, right? Low back pain is generally associated with physical inactivity, older age, poor posture, stress, and particular occupations. But if you have a red flag like this, you need to urgently treat irrespective of the person's occupation. These are some of the red flag signs, and we'll talk about it later. But let me first take you through mechanical back pain. Anybody has mechanical back pain before? Anyone? If I was in a lecture hall, I think many hands would have gone up by now. But since I can't see you and your gallery view seems to be drifting in and out, I am not unable to say. But mechanical back pain is very common. And this is because the lower back supports much of the weight of the body. And if the alignment is poor, if the muscle strength is poor, you will get back pain. And you get back pain with radicular or cord involvement. But even with mechanical back pain, you can get sinister features coming in on a background of mechanical back pain. So every episode needs to be evaluated. Mechanical back pain is usually due to heavy lifting, falls, poor sitting posture, bending and looking at phones, right? So back pain is very, very common. It's very common in medical students also. And it's usually due to poor muscle tone because the poor medical students have no time to exercise, and frequently their posture is very, very bad because of Zoom lectures and reading on their phones and computers. This mechanical back pain can come with spondylosis, spondylolisthesis, or scoliosis. Poor posture is very common, and it is commoner in middle-aged women. Can anybody tell why? Anyone? I'm waiting. Yes? I think you all have better things to do. If you so, can we just make a few suggestions so that we can move on? Yes?
Maybe because they have undergone pregnancy.
Absolutely. They have undergone pregnancy without strengthening their backs before and after pregnancy. Good response. Any other reason?
Obesity, madam.
Absolutely. So people get what is called middle-aged weight gain. So junior, I see it in my in many patients, including my students also. You start off life as a 50 kilo medical student, then you become a 55 kilo doctor, then you become a 65-year-old mother of one child, then you become a 75 kilo mother of two children because of pregnancy induced weight gain, and also life circumstances and cultural taboos against women exercising. So all these contributes to back pain that's why back pain is actually commoner in women. But men are no exemption, and they also suffer weight gain and poor mechanics. And in our country, drinking is very common, abdominal fat is very common. So again, back pains are very, very common. Most back pains will settle if you strengthen the back, right? But unfortunately, we are compelled to do x-rays, and then we diagnose spondylosis, where we see narrow disc space and bony spurs. Nobody sees bulging discs on an x-ray, but everybody tells their patient, oh, your disc is narrow, your disc has slipped, and the poor patient then is focusing on this disc and the bone spurs rather than on strengthening the back. So spondylosis, spondylolisthesis, and scoliosis can be combined with radicular symptoms, and you can have shooting pains, numbness, and tingling. And paresthesia also in the same nerve distribution. If you have a herniated disc pressing on the nerve, you can get a dermatomal or a myotomal sensory loss, but you also get positive stretch tests, and you can get a positive straight leg racing test if you have a L5S1 nerve impingement. You can get a crossed straight leg racing test where the examining the upper passive lifting of the unaffected leg reproduces the pain on the contralateral test, and this is depending on the disc where the disc is present. Also, you can get a femoral stretch test where if you lie the patient on the face and you extend the leg again, you can get pain. So spondylolisthesis is where the spine, one vertebrae slips on the other, and there are many grades of it. And with this, patients usually get constant low back pain, and they have tense hamstrings, a reduced range of movement, and sometimes they can evolve to cauda equina syndrome. So spondylolisthesis management involves stopping bending movements, and you can use anti-inflammatory drugs to reduce the pain. Physiotherapy is very, very important, but if the spondylolisthesis is clinically significant, more than 25%, you need to also use bracers. Certain patients need surgical intervention if their symptoms are refractory. Lots of us have scoliosis, and we have uneven shoulders, uneven hips, and a curve in the spine, and many degrees of scoliosis are present. Scoliosis usually per se does not cause much pain, but there is a lot of muscle strain and a sideways body posture which causes back pain. But if any of these three categories of pain, patients develop difficulty in urinating, have worsening neurological deficits in the lower limbs, have sensation loss in the perineum, perianal region, then you need to consider Cauda equina syndrome. So in general, we do not recommend early imaging unless you're suspecting a fracture, nerve compression, or Cauda equina syndrome. So this was what I mentioned earlier. And let's talk about this patient. This is a patient who has back pain for 3 days. And which of the clinical findings on examination say that this patient needs urgent neuroimaging or spinal imaging? Yes. A, acute retention of the bladder with saddle anesthesia. True or false? True.
True, madam.
Fever with flaccid paraparesis. Patient has chronic back pain but has acute back pain for 3 days with fever and flaccid paraparesis. Urgent imaging, yes or no? Fever and flaccid paraparesis.
No, madam.
Actually, yes, because the patient has got new onset neurological signs and has got fever. So we need to consider infection and cord compression due to the epidural collection or paraspinal collection. So we need to do acute urgent imaging, because especially if there is a paraparesis. How about C, numbness with no sensory deficit for pain or touch in L5 to S1?
False, madam.
False. Previous history of psoriatic skin plaques. Yeah.
False.
False. Because just because you have psoriasis, just because you have acute back pain, that is really not indicative of imaging. If the back pain is chronic and inflammatory, maybe you can investigate to check if the patient has spondyloarthritis or sacroiliitis. How about a rash with blisters in the T6 dermatome and back pain for 3 days?
False.
False. The diagnosis is possibly zoster of that dermatome, and that also can be a cause for back pain, right? So, okay. So we are going to sinister back pain, and sinister back pain can be due to infection, metastasis, referred visceral pain, pancreatitis, aortic aneurysms, or spondyloarthritis. So osteomyelitis can cause fever with localized tenderness or no fever at all, actually, sometimes just localized tenderness. So you need to consider the inflammatory markers very, very strongly, right? Cancers can cause weight loss, and the common sites are metastatic cancers, particularly in older people. And I mentioned the visceral organs. Inflammatory back pain is usually in young people, and it has insidious and not acute onset, and usually several months. There is early morning stiffness, but it's sometimes very difficult to get it from the patient, but all patients improve with exercise, whereas mechanical back pain worsens. In inflammatory back pain, there is loss of mobility in all planes of spinal movement, but in mechanical back pain, it's only abnormal spinal flexion. Okay, there are other causes of back pain which I talked about earlier. You can get osteoporotic fractures, and just plain radiography is enough. For herpes zoster, you don't need to do any imaging. And then, of course, we have the problem of psychosocial distress and yellow flags, where patients repeatedly complain of back. Lot of them are wanting compensation either from their job or from their home, right? So they need a little attention, but addressing this particular thing is very important. Otherwise, the patient will keep on coming to your clinic, keep on using resources. So if the symptom severity does not correlate with the healthcare seeking behavior of the patient or the functional status of the patient, consider that there may be a functional element to the problem. So if you were talking about, and I think that's what somebody wanted to mention, that if you consider multiple metastases, inflammatory back pain or cancer, you must always do blood tests to assess the degree of inflammation. You can defer imaging in ankylosing spondylitis, and if you have weak risk factors for cancer, or if you have imaging done for lumbar spondylosis with radicular symptoms, you can defer imaging or postpone imaging until there is a trial of therapy. But even then, if you have chronic low back pain and you have an acute worsening in the form of cauda equina syndrome, or you suspect a fracture or a superadded reason, you need to do imaging. Patient advice is very, very important, because most people don't need surgery even if they have a herniated disc. People waste hundreds of thousands and millions of rupees and dollars doing surgery without remaining active, doing weight loss and exercise. Non-drug interventions work very, very well, but doing exercises every day for the rest of your life is problematic. So this is why it's difficult to do exercises, right? So keep on motivating people to exercise. And if you follow up patients, always examine again for new neurological deficits, for new spinal range changes, because someone who has mechanical back pain today can develop a neurological deficit later. Always tell people not to lift heavy things or to do strenuous jumping up exercises like aerobics, Zumba, right? Now tell them not to stay in bed for more than 2 days because it delays recovery, and encourage them to move. Okay, waiting in bed is a risk factor for chronic back pain. And also, a lot of our ladies tend to wash clothes with the basin on the floor. Lot of people tend to carry weight abnormally, and lot of people who drive have bad posture, including me. So these things are very, very important. Low back exercises are jolly boring, but if you do them regularly, it is very, very effective. What I tend to encourage people to do is to do modified exercises, which they can do either at the gym or in exercise groups, and that works very well. A lot of our patients are heavy by the time they develop back pain, but there is nothing to say that heavy people cannot exercise. Okay, and flexibility also is very important. But always tell every patient, if your back pain changes character, if you develop new symptoms, if you lose bladder or bowel control, or if your back pain is incapacitating, to please come for assessment. Surgery is done only if there is acute nerve compression which is causing severe pain. If you need surgical decompression, or if you have cauda equina syndrome, urgent surgical referral for cancer is needed if the metastasis is causing compression. Otherwise, you need a oncology referral. right? So it's very important to also know that less surgical intervention must be considered if the patient continues to have weakness of the ankles or the feet, or if they have suspected spinal stenosis or intractable pain, which is not working with conservative treatment. Okay, so surgery is not working for most patients, but if they have a significant deficit which is not responding, and if the neurological deficit is worsening, then you need to consider surgery. Spinal fusions, discectomies are done, but that is depending on the patient's neurological need. Okay, so back pain again is very, very common. Always examine for red flag signs at every patient encounter. You need investigation and imaging if there are red flag signs. Physiotherapy and posture correction is very important in all. Are there any questions? Are there any questions? Please ask. I had to go through a big chunk of topics during this lecture, and I try to make it as easy as possible, but please do ask questions. I'm happy to answer them. There are many things that I can't explain to you in the context of a lecture, but I can always clarify your questions and answers. Yes, any questions? Any questions? Yes. Anything you want to ask in terms of any patient you all have met, any patients you all have seen in the previously, any relatives, any friends, please ask. Yes?
Madam,
Yes, Hasni?
Madam, I wanted to ask about gout.
Yes.
What happens to the levels of uric acid in acute gout, and is it a good indicator for the presence of an acute gout attack?
Thanks for the question, Hasni. It's not a very good indicator. In some patients who have gout, their uric acid levels are 9, 10, 11, 12, so high that they are high even during an attack of gout. In others, the uric acid levels are 7 or 8, but the fluctuation brings it to around 6 when the uric acid crystals home in on the joint. So you might have a person who comes with acute gout whose uric acid levels are not very high, but they are like borderline high. So you need to think of everything when you make the diagnosis of acute gout. And it's always helpful to do a joint aspiration and look for crystals. In our practice, we don't see crystals because you're supposed to look at the crystals immediately. So say I'm supposed to aspirate the joint immediately, look at the microscopy immediately. Okay? Not send it to the lab. I'm supposed to have the microscope at my clinic. That facility is not available to me. Okay? Did I answer your question, Hasni?
Yes, madam. Thank you.
Okay. Are there any other questions? I'm very happy to answer. Please do ask questions. We have a little time. I leave time because you all are final year students, and lot of the questions really add value to our lecture. Yeah? Any other questions?
Madam?
Yes, Naveen?
When we make diagnosis of rheumatoid arthritis, madam, can it be made clinically, madam? Because the criteria for ACR, it says more than 6 points out of 10 that you can make a diagnosis.
Yeah. Yeah, so the thing is, thanks for that question, Naveen. Again, Naveen, the diagnosis is clinical. So based on the clinical doctors, you can make the diagnosis even if the rheumatoid factor and the anti-CCP antibody are negative. Okay, that is the first thing. The other thing is both the ACR EULA criteria and the earlier ACR criteria are more classification criteria than diagnostic criteria, which means they are used to select people who definitely have rheumatoid arthritis for clinical trials. So they are very specific, but they may miss patients who have rheumatoid arthritis because they are less sensitive. Did I answer your question, Naveen?
Yes, madam. Thank you.
Okay. Are there any other questions? I'm very happy to answer. Please do ask. iPad, do you have a name? Any questions? Anybody has questions? Yes? The number of participants have dropped suddenly. Is it because I crashed somewhere in the middle of the lecture? My internet connection went, possibly, no? If there are any questions, I'm happy to answer. Any more, or we can end it. Where is the batch rep? What do you say? Yes?
Hello, madam.
Yeah. I can't see you. Yes. Well, are there any more questions, or shall I end the lecture?
No, madam. No questions, madam.
Okay, then I'll end the lecture. Please, I'll try to do the next CLD physically. Today, of course, it's impossible. Sorry about that. Person who did the recording, would you share the recording with me, please? Because as I said, my university computer is croaking, and the internet connectivity is bad because of power fluctuations. So sorry about all the technological malfunctions. We can upload it for the others. Okay. Right. Any questions, you can also email me on my official email. Also happy to answer. Okay. Thank you and stay safe. Are you all coming tomorrow?
Yes, madam.
Hopefully coming, no? Look forward to meeting you all. Okay. Take care. Bye.
Thank you, madam.
Thank you.
Bye.